It's always down.
Yeah.
It's new. It's like so on
It's like very new.
It's like all
And we have some a show.
like increasing.
Sorry.
So that's what I got. My face is all like really because the face makeup I use, I use CC cream and I just like the SPF. So like the sunscreen makes it really nice. So that also does. But I didn't even have that on this like today.
Michelle. that one.
Mine's just been
That's what made mine. It's not being able to.
Okay, let's pick it up with number 8. Just like we've talked about with other cardiovascular, like we talked about aspirin, we look at primary, secondary. If it's secondary prevention, they all need to be on aggressive cholesterol-lowering medicines. Primary is the really hard part in terms of preventing a cardiovascular event, or and that can be stroke or heart attack. So a lot of it will go to risk assessment. Remember the risk assessment or calculator that we put up and that we looked at? Okay, that is one you would use. If you're going to do a lot of cardiovascular risk assessment, you need that in your office. Or it may be in your EMR, either one. The one I've always used is the American Heart Association one. And you will have one again on your, you have an app for it. Okay. So we've talked about, you've seen the different factors that are included in the risk assessment, kind of in the middle of the page. Gender, age, race, total cholesterol, blood pressures, diabetes, smoking status. In 2013, new guidelines came out that guided how to choose or statin therapy or cholesterol-lowering therapy. Up until then, we judged risk based on how many risk factors you had present. The National Lipid Association has kept those. The American Heart Association has tended to move away from those. So they look strictly at, well, they look at certain risk and then they put you into a category for a statin. But the major risk factors I think are still good to know and to recognize when they walk into your office. So in the middle there, again, male over the age of 45, women over the age of 55. Family history of early heart disease. So I usually ask them, did your brother or your dad have a heart attack, bypass, balloon angioplasty, die suddenly without known cause before the age of 55? No? Okay. Well, how about your mother, sisters? Same thing. I don't care about your aunts or your grandmother. Okay? You're looking at first-degree relatives. The only time I would make an exception, and this is my own, is that they're very young and maybe their family is compressed in terms of generations. I will sometimes listen to what happened to a grandparent very young. Okay, current cigarette smoker, huge risk. One cigarette makes a difference. High blood pressure. Either it's not diagnosed but untreated, or those who are treated. Even if they're well controlled, it doesn't drop off as a risk factor. Low HDL, less than 40 in men, less than 50 in women, just like we talked about up there. Risk stratification. So they take these and they put them into risk. They're saying low risk is 0 to 1. So you have a 55-year-old woman who has no other risk factor. She doesn't have diabetes, doesn't have heart disease, doesn't have family history, doesn't smoke, never smoked. Moderate risk, 2 risk factors. High risk, 3 or more, or you have a diabetic. Again, remember we talked about diabetes being a cardiovascular risk equivalent. You consider heart failure, or you consider you already probably have it at stage A or stage 1, or it's a diabetic with 0 to 1 major risk factors. If they have chronic kidney disease, I wouldn't worry about the stages yet since you haven't had renal. Or very high LDL, 190 and above. Or very high risk would be already known to have heart disease or diabetes with 2 or more. It more goes to aggressiveness of treatment. There are several guidelines out there. The National Cholesterol Education Program has been around since 1988. And they put out guidelines that will focus on LDL goals. And they base things on that risk stratification we just went through. The American College of Cardiology and the American Heart Association guidelines, they came out 2013. If you look back at page 27, they put out this flow sheet. So pull that up. They start with, do you have heart disease? If you do, then they'll look at age. If you're between 45 and 75, then it'll tell you what intensity of statin you should be on. If you are over the age of 75 and you have heart disease, then they're giving modification to go moderate. We're going to talk about those as we go through. If that isn't the case, then they go down to what's your LDL. And then they come over and they say, okay, if you're above 190, you need to be on a high intensity. What if you have diabetes? Well, maybe high intensity, maybe moderate. Okay, so they take a different approach and they use a different lingo. They also use no set guidelines for where an LDL should be. So that caused a lot of disturbance. We're used to saying your best if your LDL is this, less than 100, or less than 130, or less than 70. They did away with that. Well, that didn't sit too well with a lot of people. So some people use a modified. They'll still use a goal. And patients want to know a goal. Where should it be? Well, it's just good enough. We put you on this, it's good enough. Because when you put them on high intensity statins, you lower their LDL by about 50%. Or if they're already low, they're already moderate, if they're, let's say their LDL is 114, but they have diabetes and they haven't been treated, maybe they have known heart disease, they'll still say put them on a high intensity. Then we're knocking them down to about 60 or 70. So it's a little bit different approach than in the past. Okay, I will come back to this. So different guidelines are out there. National Lipid Association, risk stratification, LDL targets, American Heart Association, American College of Cardiology, more based on their has heart disease, don't have heart disease, what risk factors they have, and then what intensity of statin to put them on. They do not use LDL goals. Top of page 9, benefits of treating dyslipidemias. Clear cut in people who have secondary prevention. You already have heart disease, there's lots of data that says you get great benefit from going on a statin or a cholesterol lowering. Primary prevention, much different. Men with hyperlipidemia but no known heart disease, they are considered to have benefit. Men with hypertension, multiple cardiovascular risk factors but don't have elevated lipids are considered to be to get benefit from cholesterol lowering. Men and women with an average total and an LDL average LDL and no known heart disease are considered. I think at this point we just name it vitamin S and we put it in everything. To me, when the population gets so much, you can fall into any of these categories. I am all behind secondary. My bias is I am a little bit more hesitant about primary because you're committing people long-term to a drug, and I don't take that lightly. That's my opinion. You should treat by the guidelines because that's what people will judge you over. Okay, so dyslipidemia, primary prevention. Primary prevention without known heart disease. Lifestyle should be the baseline. It should be in all of them, You need to have people's diet evaluated. Dietitian here is very helpful. Sometimes cholesterol will go down with weight, especially if they were eating a very high-fat diet. You cannot look at a person and tell what their LDL is. Obese people do not have high LDLs versus skinny people. It doesn't go with weight. You can have very skinny people with very high LDLs. You can have very overweight people with very low LDL. Aerobic exercise will help. It'll help usually men more than women because it'll raise their HDL up to a greater extent. Diet will make a big difference. And it depends on where in the United States you are. In the middle of the country where we eat a higher fat diet, it will tend to make a bigger impact. I'll never forget the time Dr. Britton and I went to California. Do we have any Californians in here? You're from California?
Oh, sorry, I said, I thought you said been there.
Been there.
Sorry. Tongue-tied.
Sorry.
Yeah.
So we went there and they invited him out to do a talk. We ran a large lipid clinic out of the VA, and we taught a lot of, and it was pharmacist run and with an endocrinologist. So we ran clinics on teaching pharmacists how to do that. So he was invited out to California to do a talk. He got booed because he talked about different levels of milk. They couldn't believe that people in Oklahoma drank regular milk, or even 2%. I suspect, they all say they just drink fat-free. I suspect they were closet drinkers. But, so different parts of the country, I think Colorado Springs, Colorado, California, wherever you are, if there's a very healthy population and they promote healthy lifestyles, they may not benefit as much from diet. But most people are going to benefit somewhat if they're a higher saturated fat intake. Because saturated fat then leads to what? The liver takes that and makes what out of it? LDL. You have any other?
How could you do Dr. Britton?
Yeah, well, they didn't like what he said. I've never seen anything like it. Okay, lowering, so LDL. So there's data on certain groups that where primary prevention probably should be used. Higher risk, certainly. Higher cardiovascular risk. But the magnitude of the benefit is going to be lower than what you see with secondary prevention. Your highest risk people to have another heart attack or stroke are those that have already had it. Whom to treat? Based it on risk. Do a Framingham. Use the calculator. So under next page, on page 10, cost effectiveness. A 10-year risk threshold of 7.5% has been determined to be cost effective. So you treat them, your prevention strategy is better. Some of the problem comes down to adherence. Statins can be expensive drugs. So at the end of 1 year, the adherence rate for statins across the board, whether people have heart disease or not, is 50% or less. It's hard to get people to take drugs where they don't perceive a benefit or they don't see a benefit. Okay? I'm healthy, I'm doing fine, and you want me to take a statin. So people may not adhere to them. Adherence is poor to start with. Young people, it's going to depend on how long do they have to take it, and is a perceived benefit outweighing the risk of them taking a drug long term. The other is it gets down to older patients. Once you get to about 75, it's unusual that people will have heart disease past that. It's kind of sub-selects. You've got people genetically predisposed or lifestyle-wise. They're usually going to be either gone or not in good shape by that age. Okay? But now people are living longer, and I've heard cardiologists argue that if they had taken a statin, they'd have lived even longer if they were 75 and healthy. So you have to start looking at that. What is the benefit down the road? How many years do you have to take it to see benefit? If you have to take it 7 years to see benefit, you're dealing with an 85-year-old, what are you accomplishing? Okay, so the young and the old, those, that is more controversial than secondary prevention, no controversy. For time's sake, I'm gonna skip over. Look at page 11, the middle of the page. Agents used to treat dyslipidemia. Now spend time on statins. They have the most data behind them. They're probably one of the easiest to take, fairly well tolerated, but lots of money has gone into them. And they've looked at it from every standpoint and every advantage. Niacin, drug's been around a long time. Fibric acid derivatives also. They were used heavily before the statins came around in about 88. 87 or 88 is when the first statin came out. Cholesterol absorption inhibitors, we'll go through those. Those are usually add-ons. Myopathies, sequestrants, also add-ons. The last two are very expensive agents. Just letting you know they're out there and can be used. Very expensive, not going to be used across the board. Okay, so let's start with the statins. What do you know about statins? Surely you know something. They're on they have commercials for them. They what? They can be hard on the liver. What else? Ton of people on them.
They come in lots of different strengths and different, God, I want to say flavors, but I don't want to do different things. But yeah, there's like the torvastatin, simvastatin, there's lots of different brands that come in lots of different strengths.
So there's a lot in this category. So anytime there's a lot in this category, it tells you they're hitting a lot of niches or there's a lot of money to be made. Okay. So here are the Hmg-Coa reductase inhibitors is what they do. That's the class name. So they inhibit an enzyme called Hmg-Coa reductase. So there's a lot of them. They're easy to remember because they all end in statin. Rosuvastatin, atorvastatin, simvastatin, tavastatin you just won't see very often. Pravastatin also not very often. Lovastatin, the first one on the market, and fluvastatin. They differ in their, they call it intensities, but their ability to lower LDL. Mechanism of action, I've already said, it's up on the screen. So the liver is responsible for making cholesterol. The rate-limiting step is Hmg-Coa. That's the rate-limiting step. So if you can knock that out, you can knock out a lot of the ability of the liver to make cholesterol. When you do that, this one's small, you'll have to work your way through it, but whenever you decrease the amount of cholesterol that a liver cell is going to make, it will eventually think, I need more. So it will upregulate LDL receptors in order to bring more LDL out of the circulation. Okay? And by doing that, then it will start to try and raise that level. At the same time, VLDL production will drop. IDL production will drop. LDL production will drop. Okay? So by inhibiting this enzyme, all those things happen. Upregulate receptors, clear more LDL from the periphery, make less of the precursors. Okay? You must know the next part. What is the effect on the lipid profile? So LDL can be lowered by 20 to 55%. The higher the intensity, you're going to see that in a minute, usually are at the upper end. It's not great on HDL, but it will raise it somewhat to a small extent. Triglycerides, they're not great on triglycerides. For the most part, they're on the lower end of that percentage. Atorvastatin is probably the best at decreasing triglyceride production. You must know this next table, you must know what's in bold. It'll make life easier on you. You will see it all, you probably run into it already at Good Shepherd, but we put a lot of people on statins. So low intensity, moderate intensity, high intensity. That's how the guidelines now refer to these. So at the low intensity, you'll see a daily dose lowers LDL on average about 30%. So simvastatin is the one that will do that. The others in there will not decrease them, well, it'll decrease it by about 30%. Moderate intensity, you must know the atorvastatin and the rosuvastatin dosing. So atorvastatin 10 to 20, lower end of the dosing range. Rosuvastatin, that's Crestor, lower end of the range, 5 to 10. Lowers LDL about 30 to 50%. And I would say for the guidelines, in defense of the guidelines, they're fairly consistent. You will run into people who they will not lower, but those are the more unusual folks. High intensity statins, atorvastatin 40 to 80, that's the high end of that range, and rosuvastatin 20. You must know those. I can guarantee you I'll ask them. Nobody in this group should miss it. You ought to start right now and say, Latassi will ask me. If you care about that point, I'm telling you right now, I will ask you. It'll save you all kinds of grief at Good Shepherd because it will come up over and over and over again. Okay, so on the next page, there's a little highlighted in there about the options. Important to know that we divide them up into 3 groups. Important to know what the impact of the LDL is, and also the names bolded. Any rotation, most of the rotations you're going to go out on that are internal medicine or family medicine, you're going to use them all the time. Clinical endpoints. So our clinical endpoints is LDL reduction, and our indirect would then be reduction in cardiovascular endpoints. So heart attack, for the most part, stroke. So who should we not use them in? Well, they work on the liver, so if they've got active liver disease, we're not going to use them. So if they've got active hepatitis, if they've got an impaired liver, sometimes you won't know until you try it. We're going to avoid them. We're not going to use them during pregnancy. They're class X. That's the old classification. That means they always could cause congenital problems. And then if they're on concurrent, if there's something else going on, one thing I didn't put on would be your transplant patients. It's not contraindicated, but you really have to use low doses with them. Drug interaction. These drugs always interact. Always look them up. Another red flag. What are your other red flag drugs? Amiodarone. Very good. What are another one? Azoles. You get a star. 2 stars. Okay. So you always are going to look them up. They're big on 3A4, so that's why they're so common in terms of interactions. Is they interact with 3A4. They're either a substrate for it, or they affect the ability of those enzyme group to work. Other things to remember: simvastatin out of this group has the most interactions, and you'll see it on the next page. Pravastatin has the least. So sometimes it's a go-to if you've got to use one and you've got other drugs that are causing trouble. The next thing, contraindicated with a gemfibrozil or a fibrate. Okay? That greatly increases the risk of myopathy. Another perfect question for me to ask is that you do not want to use gemfibrozil with a statin. If you have to use one, you use fenofibrate. Okay, look at the next page, page 13. You must know these drug interactions that are in bold. Okay? You have seen them somewhat before. Simvastatin. If you look down the list, do you not see simvastatin's name almost every time? Okay. Rosuvastatin one, atorvastatin another. Simvastatin. Don't use them with those macrolides. Don't use them with gemfibrozil. Out to the side of ketoconazole, you should just put azoles. So, because we don't use ketoconazole as much anymore. You just cannot use them together. So you look for an alternative. Usually, with the interacting drugs, you look for an alternative. You wouldn't take them off the simvastatin. So you'll notice that on the next one, simvastatin with the non-dihydropyridine calcium channel blockers, here you limit dose. Simvastatin and amiodarone, limit dose. Amlodipine, limit dose. Simvastatin and grapefruit juice, don't use them together. So grapefruit juice is a potent inhibitor of 3A4. You just have to tell most of your cardiac patients, don't drink grapefruit juice. Don't eat grapefruit juice. Don't eat grapefruits. Here's what happens. What we're worried about most is what we call is area under the curve. Okay? So this is the area under the curve. Duh. This goes to how long that drug stays alive and active in the bloodstream and can exert an effect on the tissues. What happens, so with these drug interactions, what it does is it increases the area under the curve. The big problem there then gets to muscle. The one thing that statins do is that, yes, they can hurt the liver, but they can be really hard on muscle, to the point that they break so much muscle down that it releases myoglobin, big molecule, goes to the kidney, clogs it up, causes acute renal failure. So if you have a lot of muscle damage because you increase the area of concern because you gave it with an azole, then you get increased muscle damage, greatly increase the risk of acute renal failure. Okay? So that's why we don't use these drugs, and that's why sometimes you'll see, okay, they can be used together, but we're only going to use a small dose, because the area under the curve then stays within a limit that doesn't cause the muscle damage, that doesn't lead to renal failure. Okay. Rosuvastatin, gemfibrozil. None of the statins should be used with gemfibrozil. You greatly increase the risk of rhabdo. People will do it, but the risk is elevated. Atorvastatin, you see, don't use it with a macrolide. And then you see the azoles there. Limit the amount of atorvastatin. That's the low end of atorvastatin. Adverse effects, myopathies. A lot of your patients will complain of muscle pain on statins. Usually where they complain about it's in the large muscle. So most of the ones I have ever encountered are the large upper muscles. Sometimes calves, but it's almost always. That's just my observation with hundreds of patients. Often it is worse at night. They lay down, it's like, I can't sleep. Sleep. It's every night. Usually it will start fairly early after they start taking it. I mean, after a few days, weeks. You can draw a CPK and see if it's elevated. It may or may not be. Usually you're going to have to move to something else. The one thing you can try is you can try pravastatin. Pravastatin is water soluble. It has a different pharmacokinetic profile than the others. If that one doesn't work, you don't have a lot of options in the statin world. So sometimes you lower the dose, that will help. Sometimes you can see if there's another cause for that. Depends on how much they can tolerate the myopathy. I'm saying myopathy, I mean myalgias. Sorry. So myopathies have a distinct definition. That is pain and an elevation of CPK. So cyclophosphokinase is a muscle derivative. Myalgia is muscle pain without an elevated CPK. If it's elevated, if it goes more than 10 times, I think the upper limit is like 70. So if it goes into the 700s, in our clinic we would take them off. So there's a wide safety there. If they can tolerate the pain, you could treat on through it. But a lot of times they'll want to move on to something else.
Is this like the whole time I'm taking it, or is it just when I first started?
Well, it could occur anytime, but this is my experience, it's usually doesn't take very long for it to show up. I always ask about it. You have any muscle pain? Rhabdomyolysis, this is the worst. So myalgia is like the mild, myopathy is worse, and now the next is rhabdo. So this is where you get large amounts of myoglobin being released. Can be life-threatening. Risk factors are renal insufficiency. So they're already borderline. You knock it out and they go into renal failure. Older age, concurrent administration of gemfibrozil. Niacin can also do it to an extent. They can buy niacin over the counter, so that's one of the problems there. This also occurs with your patients who have that are transplants. Rhabdo is a real problem with them, so they limit the dose that can be used of statins with transplantation. So any questions about those? That's an important one. It will show up all the time. Cognitive decline. So these drugs have been linked to cognitive decline. I understand there's a new meta-analysis out there, I haven't looked at it yet, that disputes this. But it's been thought that with long-term use, older patients, that it can occur. What the mechanism is, what the incidence is I don't have data for that. One of the bad things is because it's our go-to cholesterol-lowering drug in patients with diabetes, is it can cause new onset diabetes, or it can worsen status. Now, worsening blood sugar in somebody who's already on treatment usually is easy to manage, but it's the new onset that's the problem, because you're precipitating a disease that has consequences with a drug. So that's one thing you would monitor. So in terms of efficacy, usually you can tell in about 4 to 6 weeks the effects of the drug on their lipid profile. Usually we wait till about 12 weeks before we make an adjustment, because you will see them go up and down. LDL usually stays within a range of about 10 to 15%. Around some average for them. So they'll have day-to-day variations. So if you're seeing it go down at 4 to 6 weeks, great, keep it up, do the diet things we taught you, and then check it again in about 12 weeks. Once it stabilizes out, then checking in a couple of times a year is fine. LFTs, you need baseline LFTs. Lots of people will have transient rises with on a statin. We usually will stop it if it gets more than 3 times the upper limits of normal. A CPK at baseline is really controversial. We used to do it on everybody, and we found most people it didn't matter. But if you've got people who've got severe myalgias, it's worth checking unless they have a complaint. These drugs are all metabolized by the liver. Okay, so real world application, next page. Statins have been proven to reduce mortality. They are the first line of LDL reduction. If triglycerides are high, sometimes you have to do 2 things. Often high triglycerides will respond to diet for most people, or correcting the underlying problem. If they are diabetic and they're poorly controlled, if you will address the diabetes, the triglycerides will come down. Maybe not to normal, but they'll come down enough that they're not going to be so much of a problem. They lower more LDL than any other class of drugs. When to give them? I've got the little moon out there, so for simvastatin, lovastatin, fluvastatin, pravastatin, then you take it at night. Elevated most of your cholesterol is made at night. But atorvastatin or rosuvastatin can be taken in the morning. They're very long acting, so it doesn't matter so much with them. Monitor LFTs, pay attention to myalgias, especially when you're older. Rhabdo rare, but it can be life-threatening. Questions? Very, very commonly occurring drug, whether you prescribe them or in a group that prescribes them or are on the receiving end of other patients, you will see a lot of people on them. Okay, let's look at niacin. So niacin is a drug that's been around 60, 70 years, used to lower cholesterol. It's much more a triglyceride lowering drug, HDL raising drug. It's probably the best HDL raising drug we have. It comes in extended release, controlled release, because people tolerate it better in a controlled release. Or it becomes regular release over the counter, so people can buy it. They can read about it. People want natural, they may go that way. It's a very good drug, but it has some side effects that can get them into trouble, so they need to be monitored. Big note, niacinamide is not niacin. Patients will confuse them. Sometimes they'll pick it up. I've seen providers write for it instead of niacin. It will not lower cholesterol. So it's the niacin that does it. How it works, people don't know exactly how, but it decreases fatty acid release from the fat stores. It's why it's so good at triglycerides. So most effect is on fatty acids. If you look at lipid profile, you must know these. Modest LDL, so probably equivalent to what you see with the low intensity statins. HDL, there is no drug better, 15 to 35%, but there is no indication to use it for HDL raising. Triglycerides, very good, 20 to 50% on par with the fibric acid readings. So this drug works well on 2B, pattern 2B, elevated, modestly elevated LDL, elevated triglycerides, low HDL. Very good on 2B pattern. Contraindications, liver disease, like we saw with the statins. Severe gout, it raises uric acid, and it's pretty strong at doing it. So if they've already got a diagnosis of gout, avoid this. Peptic ulcer disease, it's hard on the stomach. If you go back and look at where this came from, it was based on a case report of 7 people who had, and this was in the 60s before they did scopes, that they attributed peptic ulcer disease to the taking of niacin. It still retains that contraindication though. And then arterial bleeding. This drug interferes with clotting factor production in the liver, so they can get increased bleeding times on niacin. Precautions would be diabetes. It will raise blood sugar. High alcohol consumption, mostly because of the flushing that you get with it, upset stomach, and then gout. Drug interactions, statins, so it will increase the risk of myopathy just like the fibric acids do, so don't use them together. And it can raise blood sugar. So it's very famous for flushing. Here's a lady about 30 minutes after she took niacin. So it's a vasodilator. And so people usually within 30 minutes of taking it will get a very significant vasodilation, flushing. They also may get a tingling sensation along with it. So the one people hate the most, and it's mostly men who really hate it, is the flushing. Anything that also vasodilates, so taking it with alcohol, no. Or unless you want the flushing. Taking it with hot liquids, or like when they take it in the morning, we always ask them to take it on a full stomach. They'll get the flushing just because of also the hot liquid. So one of my friends I worked with at the VA, he had heard us talk about this, and so he was at a party, and I don't know where he got the niacin, but he had drank some beers, and he said he was going to try it and see what it was like. So he did. So he told me that the next thing he knew, now this was in the wintertime, So the next thing he knew, he had stripped down to his boxers, went outside in like 30-degree weather, and held out his arms just so he could dissipate the vasodilation. So it can be very significant. So don't drink alcohol with your nose. It's the best story. So it's prostaglandin mediated. So one of the things we can do, and what we teach patients to do, is take an aspirin before you take your niacin. About 30 minutes ahead, knocks out the prostaglandins. You can take the niacin. If you're going to use it, you have to start low dose and titrate up. People will become tolerant to the effect. This does go away. Most people don't get past this though. So if you're going to use niacin, it takes a lot of patient education to work with them in time. And so patients know statins available, they may not even want to mess with niacin. Niacin doesn't have the studies behind it. It's a generic drug, over the counter. Nobody's going to make a lot of money off of it. The extended release, though, are more tolerable. The biggest thing with them is they increase the risk of liver disease or liver toxicity compared to the regular release. Hyperglycemia, dose-related, higher doses are more likely to do it. Hepatic dysfunction, more with the extended release. Really important, if you put them on, you've got to, it limits the dose and you need to follow ALT, AST. Severe dysfunction, look at that third under hepatic dysfunction, third bullet. Severe hepatic dysfunction, most likely when switching from an immediate to an extended. Hyperuricemia, do not forget this one. You can cause people severe gout attacks who already have elevated. In our clinic, we wouldn't start anybody who had a uric acid already above at 7 or above, even if they didn't have a diagnosis of gout. And then cardiac or upper GI distress, always tell them to take it with food. Monitoring. So again, about 4 to 6 weeks to check a lipid profile. About 12 weeks for it to stabilize, and then periodically once you've got them to goal. You've got to monitor LFTs, got to have them at baseline. If you're going to put them on the extended release, you have to follow that, continue to follow those. Blood sugars, uric acid, I'm going to add that one. And CPKs if muscle symptoms become a problem. I will say that by themselves, I've never seen them cause myalgias or a myopathy. But with a statin, you can see that complete. So real world, no strong studies showing a decrease in mortality or cardiovascular mortality or other significant endpoints. It's an option in people who can't tolerate the statin, especially if they have a 2-beat pattern, especially if they have higher triglycerides. It's the most broad spectrum. It does everything we want, but it's hard for people to take. When switching from immediate to a long-acting, dose it at 50%. So keep that in mind. If I'm going to make a switch, I can't switch 1-to-1 dosing-wise. If you're going to use a long-acting like the Niacin, start with 500 a day and increase by no more than 500 at intervals of 4 weeks. Watch the liver all the time. The other downside with immediate release is that it has to be dosed 3 times a day. In our clinic, we found we could get good effect with twice a day, but the recommendations are 3 times a day. I have found if people are looking for more natural or things they can control themselves, people may go to niacin. So keep it in mind in asking. People can also get cholesterol monitors over the counter. So they could do all this on their own, under your radar and not having you mess with them. So just keep that in mind. Okay, questions? All right, I'm going to talk to Dr. McNeil. I'm going to negotiate some time with him and look at finishing up this tomorrow. So did the initial part help or not?
Yes.
Okay. Well, that cost us our time. So I'll talk to him and I'll send you out an email. So hang on to your handout. All right, well, I'll probably see you tomorrow, and then I'll see you again on Thursday for it next week.
Like, I mean,
It kind of does, but it's I'm not making hundreds.
right, or just fasting, and you have to go with your own and buy that.
I was almost bad on so many reasons. My computer almost fell, and I tried to touch it, and I almost pushed this water off. Lay it.
I'm just gonna go.
Got my heart rate up.
I just pulled up our calendar. That's like nails tomorrow.
What time was that?